Well, we're now joined via Zoom by UNAIDS Director for Science, Systems and Services, Dr. Fode Simaga, as well as the National AIDS Commission Director for South Africa, Dr. Thembisile Xulu. To both of you, thank you very much indeed for joining us and welcome to the program.
Thank you.
Thank you. Good evening, all.
Let me start with you, Dr. Simaga. This meeting, this gathering, comes at a critical time, and some might say that it's actually an emergency meeting. What has prompted this?
The fact is, as your subjects demonstrated it, there is a sense of urgency around the prevention. We failed our target. Last year, we count for about 1.5 new infection instead of the 500 targeted for 2020. And now we are targeting 375. The reality of the cost of failed HIV prevention is not immediately visible, you see, so it's not appear to the people that we have to do something, but there is an urgent emergency, a political emergency for political leaders, to speak out and to making the investment. There is implementers, emergency needed, as well as lawmakers. Just listening to you on your previous subject, you see how things could be difficult for the most vulnerable people. So this is we are thanks South Africa to us with about these 28 top countries, the most affected country, if I can say, to really came together, identify the best way to move quickly and what is needed in terms of money, in terms of support, in terms of action at country level. So basically, it's like we want to close the gap, and to close the gap, we have to be together, and raise the alarm. Thank you.
Dr. Xulu, these 28 countries make up, 75% of all new HIV infections. South Africa has always had a challenge in terms of the numbers and the rates. Have we followed the trend of this increase as well?
Yes, thank you so much for the question, Peter. We have followed the rate in terms of the trends, and I think unfortunately, as Dr. Fode explains, South Africa is not where we should be in terms of the commitments that we made for prevention targets. None of the 28 countries actually reached the 75% reduction of new infections by 2020 as we had planned. And it's for a multiplicity of reasons, from lack of proper estimates to inadequate funding, to the increase in adolescent girls and young women, which we see in sub-Saharan Africa mainly. And I think COVID-19 has also not made the situation much easier because there has been competing priorities in terms of funds. So I think South Africa also has not met its target. We had planned to be below 100,000 by 2020, but we are still way above that in terms of new infections. So we have been following that. And it's time now for us to accelerate our prevention efforts, improve the pool in terms of choices, and really accelerate our commitments.
Why would things get better if we've been struggling so far? What's different now?
All right, so I think, Peter, from our end, I think what we did discuss at the meeting today is that sometimes just committing, it might be a good gesture, but it does not always result in implementation. So what we have done is to identify top 10 priorities that countries do need to commit to. But one of the key things that we've said we are going to do differently is holding each other accountable. And we've actually defined what that accountability means in the meeting that we had today. And accountability essentially starts with understanding what our targets are, which means we need proper estimates in terms of the key populations, as well as the young people where new infections are coming from. When I speak accountability, most people might think that it's about donors, for instance, that fund prevention projects, holding implementers accountable. But at the same time, there is an element of us as implementers holding ourselves accountable, but also including the most marginalized, as well as the communities or the end users of the service in the accountability. I think there's also the need to identify bottlenecks and to improve on those. So Peter, now, when we've got quarterly targets, for instance, we cannot wait for the end of the quarter to review our performance. We need to be reviewing how we are doing 2 weekly, monthly, so we've got adequate time to course correct. And most importantly, prevention can't just be a health or a government priority. It needs to be a multi-sectoral response, which means we need civil society, government, private sector, as well as our development partners supporting us. So I think it's more precision around the way we respond and hold each other accountable.
All right, Doctor.
If I may, Peter, there is also something very specific. As you might know, and thanks to all the countries across the world, including sub-Saharan countries, which contribute to the global fund replenishment. So despite all the competition or competitive priority, Ukraine, everything, few weeks ago, you should know that 14.2 billion was raised for the 3 diseases, HIV, malaria, and tuberculosis. Very soon, all the country will have, and it's their responsibility, to apply to global fund grants, and is the key funding, apart some exceptional countries like South Africa, where the domestic funding is so huge, thanks to the government of South Africa. But for all the others, including South Africa, applying to global fund will be essential. And usually, till now, prevention has been lagging behind. So what will change is that these 28 countries, part of their accountability will be to put at the higher level possible the prevention funding in their country. And with that funding, we have all the tools. We know what to do. The team do absolutely will go to work and make things different and target the population. But we need funding. And this is the opportunity to get funding for the next 3 years.
All right. So the funding story perhaps looking like a solution being found. To describe what these precision prevention programs will look like.
All right, so from a South Africa perspective, I think the starting point, as I was mentioning, is that it's important for us to have a key understanding of what the key population estimates look like, so that when we look at the social and structural barriers that prevent them from accessing the system, we understand where they are so that we can allow them to come forward and access the system. It means that our response is data-driven, which means we are looking at the data constantly in order to be able to implement programs that are relevant. When we are precise, Peter, it means that we are offering solutions that are appropriate to particular populations. As I said, when we increase the pool of prevention tools, whether it's pre-exposure prophylaxis, be it oral or long-acting injectables, or condom usage, we are able to say, in this particular area, it's young people. These are the solutions that are appropriate for young people. These are the solutions that are appropriate for pregnant women so that they don't transmit HIV to their unborn babies. And these are the solutions that we need for men. And these are the solutions that we need precisely to be driven at community level versus what health facilities can handle, based on the burden of other diseases that they're handling. So being precise means being data-driven, but understanding your epidemic and understanding what your prevention needs and priorities are as a country.
Dr. Simaga, it does sound that each country is going to have a unique profile and obviously unique solutions. I wonder, though, what is it about these 28 countries that is typical to all of them that puts them in this high percentile?
I mean, first, I don't know, maybe I'm not sure I get you fully, Peter, but each country will have to tailor to their context what are their response the best. And it came with what Dr. Thembisile just said. You need to know your epidemic first. You need to know the percentage, basically what we call population location. Where are the population the most affected, the most vulnerable? We know that in many of the countries on the world is around urban area. That is also a new dimension, you know, urban and suburban. You need to know, so population, location, and there is several tools was exposed by Dr. Thembisile, maybe just to add the voluntary male circumcision, which reduced by 60% the risk of transmission and was hugely affected by the COVID-19. So these 28 countries have the similar global epidemic profile, which we call generalized epidemic. It's like high-level prevalence as well as high-level incidence. It's not only in Africa. You have countries like Pakistan, Indonesia, China, etc., that are part of the 28. So this, and also, to be honest, is the similarities also their willingness to move, you know? It's like they were volunteers to work together and to learn from each other, to see and to help the world to understand what are the different tools that science demonstrate, because we should be driven by science, not only for data, but for action, but also what we call combination prevention. There is not one magic tool alone that can deal with anything. You have to combine all those tools, PrEP, oral treatment, which we use, you know, maybe you have heard about U, indetectable equal intransmissible. You have to do the elimination to mother to child. You have the voluntary male circumcision. You have different tools like that that you have to adjust to your population or your population you are targeting. And that's why government alone couldn't do it. Neither civil society alone. It has to be a joint effort going beyond a vertical approach of HIV. It has to be a multi-sectorial approach. It's mean very concrete things for us. You know, it's not a word. It's like, you know, your subject was that. How do you deal with sex workers without working with the police? You know, but then you have to, and it's not easy. So that is the challenge. So I'm not saying the money alone will solve every problem, but the funds will help to implement what the science has demonstrated what works, and will help leaders like Dr. Thembisile and our colleagues who know very well, and the Ministry of Health, what's going on in South Africa, to deploy the right tool for the right population. And that is where the success will come in.
Dr.
Xulu,
yes, I get that now. Thank you so much for that. Dr. Xulu, what is it about this age group, 15 to 24, particularly in our young women and adolescents, that makes them so vulnerable?
I think, thank you so much, Peter. Yeah, we've looked at this in many ways, and it's a multiplicity of factors. I think from the fact that, you know, when you look at adolescent girls and young women, the biology is such that they are more prone to infection if there is early sexual debut. I think you find that there's a whole lot of economic issues that result in adolescent girls and young women being financially dependent on older men, because when we look at the trend in terms of who is infecting our young girls, we find that, you know, on average, it's men that are 8 years and older than they are. So there are some structural factors, including level of education. You know, when they are out of school, some of them need economic support, and they end up depending on older men. There's also some level of low perception of risk in our young people, and I think lately what's been concerning, Peter, is some harmful, you know, social and gender norms which seem to be returning. And one of them in the province of KwaZulu-Natal is the culture of ukutwala, where young women are forcefully married, which means it could be a young girl under 16, that would be statutory rape. But if she's married, you know, to an older man, she is impregnated, exposed to STIs, exposed to HIV, you know, early unintended pregnancies. South Africa still has a very high rate of gender-based violence and femicide. And we know that women that are exposed to intimate partner violence are 3 to 4 times more likely to be infected with HIV. So it's a whole plethora of reasons that actually result in us seeing such high levels of infections in young people, especially adolescent girls and young women. Hence, our programs are now tailored for young people, including adolescent boys.
Dr. Simaga, Dr. Xulu, we're going to have to leave it there. We wish you the best with the deliberations in the remaining time that you have together. And let's hope we can get back on track and get back on track quickly. Thank you for your time.
Thank you for your invitation. Have a good evening. Bye.
Thank you. Good night. Thank you.
Bye.
All right, so there you have it. UNAIDS Director for Science Systems, Dr. Fode Simaga, as well as the National AIDS Commission Director for South Africa, Dr. Thembisile Xulu, speaking to us about UNAIDS driven meeting. 28 countries in particular responsible for 3/4 of the new HIV infections. And sad to see 15 to 24-year-old girls and women particularly vulnerable to new infections.